Okay, good afternoon to you all, and greetings from Houston. I'm Maksim Mamonkin. I'm a faculty member at Baylor College of Medicine, and I'd like to thank the organizers for the invitation. And unfortunately, I cannot be there in person. But today I'll talk about the development of CAR T cells for T cell ALL and discuss the current clinical development, where we stand, and outline some future directions. These are my disclosures. So we all know that CAR T cells are working very well in B cell leukemia, but their development in the T cell ALL is a bit more complicated. And that's because the majority of antigens that we can target with a CAR are expressed in both normal and malignant T cells. And that increases the possibility of CAR T cells targeting each other and inducing fratricide or self-elimination, which obviously may impair their expansion. Depletion of normal T cells is a much bigger problem than B cell aplasia, as it can lead to immunodeficiency that we cannot really compensate by other methods. And obviously, T-ALL is very frequently present in peripheral blood, and we can inadvertently modify them with the CARs during manufacture, which could lead to antigen escape. So we really need to solve all these three problems to develop safe and effective CAR T cell therapies for this disease. So by far, the most advanced antigens in preclinical and clinical evaluation are CD5 and CD7, which are shown on this table. You can see that both of them are expressed in the majority of T cell ALL, as well as in some mature T cell neoplasms. And the big problem is that both CD5 and CD7 are very widely and highly expressed on majority of peripheral circulating T cells, which predisposes them to self-targeting and elimination. However, the expression of these antigens in other critical tissues is minimal. So if we can solve these problems of cell targeting, these become very attractive target antigens for T-ALL. So we'll start with CD7 because it's expressed in the wide majority of T-ALL and lymphoblastic lymphoma. It's very bright, typically on the blasts, and is one of the best, if not the best, antigens to target in T-ALL. Just because CD7 is expressed in the majority of T cells, usually the manufacturing outline for these CAR T cells include an additional step during which the CD7 is disrupted, usually using either CRISPR-Cas9 or CRISPR base editing or protein expression blocker. So my group has shown several years ago that we can very effectively disrupt CD7 using CRISPR editing and before expressing a CD7 CAR on those, and that results in the expansion of fratricide-resistant CD7 edited CAR T cells with very high activity in preclinical models. Other reports were published around the same time using protein expression blocker by Daria Campagna's group, as well as the combining CRISPR edits with TCR ablation to create an off-the-shelf T cell product by John DiPersio's group. In the last couple of years, there have been several clinical trials reported using CD7 CAR T cells that were generated either from autologous patient material or from donors, either prior hematopoietic stem cell donors or prospective donors, as well as fully off-the-shelf third-party derived T cells. They use different methods of fratricide prevention by disrupting CD7 expression, as I showed in the previous slide. And all of them showed fantastic outcomes in patients with primary refractory and relapsed disease, showing upwards of 95% of complete remission rates in these patients. The vast majority of these trials were conducted in China, and one just came out recently in New England Journal of Medicine, a trial performed in the UK using CRISPR-based edited CAR T cells. In the majority of these reports, the investigators noted that the aplasia of normal T and NK cells was largely avoided by repopulation with normal CD7 negative lymphocytes, which comprise a minority of normal lymphocyte pool, but in these patients, they expand and persist and resist CAR T cell targeting just because they naturally lack target antigen expression. However, the investigators still noted the increased incidence of infections, bacterial, viral, and fungal, and in some cases, these infections were lethal. In several patients, an antigen escape phenomenon was noted, just like we see CD19 antigen escape in B-ALL. So this is not unusual, but it also indicates that other targeting approaches should be developed to capture these patients. Because additional methods of fratricide prevention are complicating the generation of T cells, we've developed an alternative method in the lab where we do not really do anything else to prevent fratricide. And instead, we just expand our CD7 CAR T cells without any additional editing in the presence of tyrosine kinase inhibitors, ibrutinib and dasatinib, which are very good at blocking CAR signaling that leads to fratricide. And expanding in the presence of these two inhibitors allows us to generate a lot of cells that do not produce self-targeting just because CAR is not signaling. And post-infusion, the naturally CD7 negative cells, which are a minority in the initial starting material, they survive fratricide and expand and persist. And we have validated this in mouse models, in the xenograft models of human T-ALL, where we show that these CAR T cells not just survived, but actually expanded and persisted in these animals and produced very long, durable protection against leukemia progression. So we have recently translated it to a phase 1 trial at Baylor College of Medicine, which is led by Dr. Makisa Hill and Dr. Rain Rouse, in adult and pediatric patients, respectively. We will enroll patients with T-cell malignancies, CD7 positive disease. It's a standard dose escalation trial with 3 dose levels. It's designed as a bridge to allo transplants, which means that if patients achieve a response, they are recommended to proceed to an allo transplant. And then we evaluate the final CAR T-cell products for the presence of CAR-positive malignoblasts to make sure we're not infusing them back. And we are seeing, indeed, just like in mice, we are seeing that in human patients, our CAR T-cells expand and persist long-term. And they are capable of producing very strong anti-tumor activity in patients with systemic T-ALL after a single infusion, as you can see here. Overall, we treated 7 patients on the first 2 dose levels. In the first dose level, we didn't really see any evidence of response. But in the second dose level, all 4 adult patients responded very well, including 2 MRD negative CRs, 1 mixed response with a loss of CD7. So we're also seeing CD7 antigen escape, and 1 very good partial response in patient with cutaneous T-cell lymphoma. I do have to note that the responses in pediatric patients, we've treated 3 patients so far, remain quite poor because unfortunately, the patients have very high disease burden at the time of treatment, and as a result, CAR T-cell infusions don't really produce a lot of clinical benefit. So what about targeting CD5? CD5 is an alternative antigen. It's also very highly expressed in T-ALL. It is a bit less prevalent than CD7, but it's still expressed in the majority of cases at very targetable levels. Again, just like CD7, CD5 is present in the majority of peripheral T cells, which increases the risk of fratricide, just like with CD7. However, what we found early on is if we express an optimized CD5 specific CAR, that results in very effective removal of CD5 from T cells, from the cell surface, internalization and degradation of its protein in cells. So in the end, we don't really see any evidence of the protein in our CD5 CAR T cells because this protein is being degraded all the time as it's being made. At the same time, production of RNA remains intact. And as a result of this very effective process, the CAR T cells become invisible to each other and are able to expand and persist very nicely during manufacturing. And once we co-culture them with target cells, we're seeing very nice cytotoxicity, and this is activity against circuit cells. You can see that they're eliminating the targets very well and also producing good protection in mouse models, xenograft models of T-ALL in 2 different instances. So encouraged by these results, we also went ahead and translated to a phase 1 trial, which is also led by the same investigators as the CD7 trial in our institution. It has a very similar design. We treat both adult and pediatric patients with CD5 positive disease as a bridge to transplant as a single infusion on one of the 3 dose levels indicated here. And also, just like with CD7, we make sure that we're not infusing products with detectable malignant cells that express the CAR back to the patient. So in the first cohort of patients, we treated 8 patients with primary refractory or relapsed disease. We saw very disappointing results. We saw that the CAR T cell expanded, but very quickly crashed. So their persistence was not very long. And as a result, we didn't really see a lot of evidence for response except for one patient in whom we did see very transient MRD positive remission, but she unfortunately relapsed very quickly after that. We started looking at the products that we infused to these patients and very quickly realized the problem, which is the CAR that constantly engages CD5 and induces its degradation in T cells. This process produces continuous photonic CAR signaling, which increases T cell differentiation. And as a result, it depletes the beneficial, minimally differentiated, naive-like and central memory cells that you would normally see with control CAR T cells. In the CD5 CAR T cells, these populations were depleted. So really, the cells that produce long-term activity were lacking in our products. We have developed a method to avoid this problem using the same tyrosine kinase inhibitors that are shown in the CD7 process, ibrutinib and dasatinib, and both of them are blocking different parts, different kinases in the signaling pathway of the CAR. And as you can see in these CAR T cells, the tonic signaling from the CAR is completely blocked, and this resulted in the preservation of these minimally differentiated naive-like and central memory cells, which produced much better activity in the mouse xenograft models of TALL. So we went ahead and implemented that in the GMP manufacturing and treated several patients with CD5 CAR T cells that were expanded in the presence of dasatinib and ibrutinib, but we do not treat patients with these inhibitors. We discontinue that before the product is frozen. And so what we found out is that the products that were manufactured with TKIs expanded roughly to the same level as the non-TKI group, but persisted much, much better. The persistence of these products were much longer in these patients, in the majority of these patients anyway. And importantly, this resulted in a much better responses. So out of 8 patients that were treated with the new protocol, 6 responded very well, including 5 MRD negative complete remissions, as opposed to 1 MRD positive complete remission with the prior process. This very clearly indicates that we do require functional persistence of our CAR T cells to produce durable clinical benefit in patients with T cell ALL. And so finally, what is happening with normal T cells? Are they ablated? Just because, as I mentioned before, the majority of them are CD5 positive. We do see a reduction in the counts of circulating T cells post-infusion compared to pre-lymphodepletion. However, we never see complete ablation of these cells. And what's happening here is that shortly after injection, as CAR T cells expand, the normal T cells convert from CD5 positive to CD5 negative, and the CD5 negative T cells persist as long as CAR T cells persist, and they comprise, majority of them are CD8 positive, some of them are CD4, CD8 double negative cells, but they are polyclonal. They also express different TCRs, and we think they produce protection of these patients during the treatment. So I will conclude here, and hopefully I was able to convince you that CAR T cells that target either CD5 and CD7 are feasible, and we can manufacture them with or without additional engineering by using tyrosine kinase inhibitors, which prevent fratricide or detrimental tonic signaling. We are seeing good evidence of activity in patients with refractory and relapsed ALL and lymphoblastic lymphoma. We can increase the activity of CD5 CAR T cells by blocking the tonic signaling with ibrutinib and dasatinib. And the aplasia of normal T and NK cell subsets was limited just because we are seeing a replenishment with the CD5 and CD7 negative populations, which persist throughout the treatment. And to close, I just wanted to outline some challenges that we have observed in these patients, and that can be addressed by new approaches that we and others are currently developing. Obviously, TALL is a very rapidly progressing disease, and frequently the patients have a lot of disease. They're filled with leukemia cells at the time of treatments. And so if we can treat them earlier and try to collect them earlier so their cells are in better shape, or maybe develop allogeneic or off-the-shelf products that will allow immediate treatments without waiting for the patient to progress, even on bridging chemo. So this is a very important area of development right now. Antigen escape, obviously, it's not a new phenomenon. We are seeing that in B-cell ALL, but it sort of raises the question, should we also use combinatorial antigen targeting, just like we use in CD19 and 22 with CD19 and 20 in B-ALL. And there are alternative antigens. We can combine CD5 and CD7, but also there are alternative antigens that could be used in combinatorial setting. And so these approaches are currently in development by our group and by others as well. Increases the frequency of infections and reactivations of endogenous viruses, predominantly herpes virus, CMV and EBV, has been noted in patients treated with both CAR T-cell products. And so that underscores the importance of limiting functional persistence of CAR T-cells. We cannot let them persist for months and years like we see CD19 CARs. In some of the patients with B-cell leukemia, we cannot really allow this, and we have to limit the persistence of CAR T-cells either by using the right CAR design or by using suicide switches or other ways of limiting their activity. In several patients with lymphoblastic lymphoma, we did observe a limited infiltration and trafficking of our CAR T cells to the pleural cavity. These patients frequently have mediastinal masses. And sometimes we see fantastic expansion of CAR T cells in peripheral blood, but very few, if any, CAR Ts in the pleural cavity and pleural effusion. So that suggests that the trafficking may be impaired, although the number of these patients is still too low to make a definitive conclusion. And finally, is this destined to be always a bridge to transplant, and we can use that as a standalone therapy? We need to accumulate more data, and I think current evidence suggests that the lymphoablation is not catastrophic, which raises the question, can we actually do it as a standalone and not mandate a transplant after this? So I will stop here and acknowledge all the people that were involved in the studies, members of my group. I'll try to highlight some of them along the way, as well as the members of GMP, GLP, the leadership of CAGT, the clinical team, which is absolutely fantastic, and the regulatory group at our center, as well as funding sources and patients and their families. I'll stop here, and we'll look forward to the discussion. Thank you very much.